With March being Endometriosis Awareness Month, I'm delighted to welcome Mr. Anthony Griffiths, an accredited endometriosis surgeon with the British Society of Gynaecological Endoscopy. He is responsible for establishing the first tertiary endometriosis referral centre in Wales, with 63 specialist centres across the UK, and has trained numerous consultants who have gone on to lead very successful endometriosis services right across the UK. Consultant, obstetrician, gynaecologist and endo specialist, Mr. Anthony Griffiths, who you will know better as Mr. G from my blogs. Welcome, thank you for joining us. To start with, would you mind just giving us a quick brief overview of what endometriosis actually is?
Yeah, I'm almost going to give you two definitions. The more traditional definition, which is part of our national guidelines, our NICE guidelines. And you could define as endometriosis as a condition where tissue similar to the tissue that is inside the womb that's shed every month is located within the pelvis. And that sounds like a very simplistic way to describe it, but there are kind of other ways to define it. And a more accurate way is it is a genetic condition that is really causes a whole body systemic inflammatory process, really. So it is a lot more than just spots in the pelvis. Classically, it can present with agonizing period pain. One of my almost favorite classical way of defining endometriosis pain is hundreds of women I've seen and operated upon who've had children, and I've asked them all, I said, what is childbirth like? And they all say without prompting, the childbirth pain hurts a bit, doc, but nothing like my endometriosis pain. This pain is absolutely debilitating agony, as well as pain associated with periods. It can cause pain throughout cycle, pain radiating down legs like a sciatic type pain, lower back pain as well, abdominal bloating, but it affects bowel. People get significant like IBS type symptoms, constipation, diarrhea. Can affect bladder, people with like a UTI type symptoms, but they have no infection. People present with blood in the urine, pain on passing urine, but also some people present with they cannot pass urine. They've lost that ability. Pain on intercourse is agonizing pain where people just stop having sexual intercourse because the pain is so bad. Messes up educational attainment, destroys employment, but people have to take sick leave because they're non-functional, and then often employers don't quite understand how bad this is, and so the lack of support really affects relationships, financial attainment as well. And all these things, if you think about it, brings you to depression because of what you're suffering. And if you think about these things as well, there's surrogate risk factors, which I'm particularly concerned about, is suicide. That I believe that people with agonizing pain that they can't get help are so desperate, and so many people come and see me and they've considered suicide, and yet we don't seem to be addressing this adequately in the United Kingdom.
What signs should we be looking out for if we're not sure we even have the condition?
Yeah. It in some ways it's quite an easy diagnosis to make, or should be an easy diagnosis, but unfortunately in the United Kingdom, between suffering and getting a diagnosis, the average in the UK has gone up from 8 years to 12 years. 12 years of suffering before somebody says, I wonder if you've got endometriosis. And you can ask people 3 questions, and they're quite specific each on their own. But if you say yes to one of these 3 questions, your probability of endometriosis is in the upper 90%. And the first question kind of defines what normal period pain should be. And it's pelvic pain more than mild analgesics. So rolling round the ball, curled up in agony, non-functional, going to bed, that is pathology. And we've almost got to get this idea that severe pelvic pain is not normal. So normal period pain, I often say, should be, I'm watching a television show, the show is so good, I forgot to take my paracetamol, and that's period pain. More than that is abnormal. So that's quite a good surrogate marker in itself. Time off school or time off work, or when you start a future plan where you start using your diary and you say, oh, shall I go to that party? I'll just check. Oh no, I'm scheduled for agonizing pain that weekend. I won't go to that party. So you start kind of changing your social life because of cyclical pelvic pain. And the third thing, which I find the most fascinating of all those things, is ever use a hot water bottle, and I don't mean for cold feet, I mean I see many women in offices with hot water bottles, 2 of them, 3 of them, sometimes they travel everywhere with hot water bottles, and they migrate from using tap water to using boiling kettle water. And if I put my hand on it, I can't touch it, it will burn my hand, and yet they can hold it on their abdomen and they get burn marks on their abdomen, and they kind of blocking the pain receptors of endometriosis by having the excruciating pain of burning, but that is surprisingly less. If you identify one of those 3 symptoms, your probability of endometriosis immediately is in the 98%. But there's other things as well. Unexplained infertility, the most common cause of pain deep on intercourse when people stop having intercourse is endometriosis. So it doesn't have to be that classic presentation. Some people present in slightly unusual ways.
So with the less common ways of presenting, how would you go about identifying, or how would someone suffering those things go about identifying that potentially this could be endometriosis but not presenting classically?
So it's almost, for instance, a population that often are missed is people who don't have regular periods, so they don't get regular period pains, or people with this thing polycystic ovaries, which again 50% of the population have got, so they don't have regular periods, but they present in a more insidious way. They describe as pain started intermittently, then it progressed to pain throughout their cycle. Fatigue is often linked to it, actually. If you rank people's symptoms, fatigue is often in the top 3, that endometriosis is a pro-inflammatory condition. It secretes or creates the same molecules that you make when you get the flu. You feel awful and achy and shattered within. So I think it's thinking pain is abnormal, and we've got a problem in the United Kingdom, actually in most of the developed world, and it comes from the 1950s, where the idea of women should suffer in silence, or period pain is normal. A classic thing is if I went to see my general practitioner with a sore elbow, he would treat that seriously. But there's a kind of culture in saying, well, because it's period pain, it can't be that bad. It's normal, have some paracetamol, and he's kind of downplaying the suffering people have got.
The research that's come out recently about possible tests that could be used for diagnostics with the menstrual blood and things similar to in menstrual fluid, detecting proteins that could be indicative of endometriosis. This, if it goes well, and how people are hoping it will, then it could vastly reduce the amount of time it takes to get a diagnosis. Have you been involved in any of this research, or what's your take on this?
Yeah, so we've got some really interesting diagnostic tests, and we are desperate for a test. In some ways, I often say the diagnosis, it is easy, and the greatest diagnostic tool you've got as a doctor, as a clinician, as a healthcare professional, is always your years, and it's just listening to the story, and the patient's already told you, essentially shouted you, I've got endometriosis, I've given you all the symptoms already. So almost the diagnostic test then is a confirmatory test in some ways, whereas it's the key to suspect that at the start. You've got biochemical tests that start in existing, saliva tests, menstrual product tests, and it's kind of more than one protein, and kind of artificial intelligence has aided us in developing diagnostic tests. There's other biochemical tests as well, or biophysical tests in terms of imaging. There's a society that we set up, which came actually from Cardiff 18 years ago, and it was the British Society of Gynae Imaging, and we've worked with our Royal College to drive up transvaginal scanning, to use other ultrasound modalities. We can now look at endometriosis in the rectal wall with accurate ultrasound. We've got some really clever MRI technology as well that has massively improved in the last 10 years, and also the reporting skills have improved.
So one of the biggest issues with endometriosis that I found is the length of time that it does take to get diagnosed. Why do you think this is such an issue when, as you say, it shouldn't be? Because the technology is there, the knowledge is there. Why does it take so long?
Yeah, there are many barriers, and I think the greatest, and this is really sad but true, there is inequality in healthcare between males and females. I know we've looked at waiting lists for operations, and you can look at specific operations. You can look at even non-gender specific operations, and women wait more than men. And that is really sad. There was a very good Canadian study that said being female, having the same pathology as a male going for an operation, your complication rate as female is higher. There's very good publications say if you present as a female compared to male, you are offered less analgesics because you're perceived you're in less pain. And this is really bad. And as a male gynaecologist, I always feel really ashamed and embarrassed by this fact, to be honest. I've done a study of like the history of endometriosis and the appalling things we did to women who were suffering in history. The Victorian age did terrible things. If you complained of pelvic pain in the Victorian age, they would lock you up in an asylum and say, well, you're obviously insane because you don't want children, or you're complaining you don't want a sexual relationship with your wife. So by definition, you must be insane. And they did awful things. They did a clitoridectomy. They removed the clitoris on women, and they found it was more effective if you did it without anaesthetic for relieving pelvic pain. Well, everyone was too terrified to say they had pelvic pain. And you could argue we've improved in over 100 years, but still we've got really good evidence we are ignoring women's call for help. That it needs a massive cultural shift, so that's societal. And there's various ways to do that. I think it's really constant education, be it political from the top. But I think of all the tools we've used, political, we've used education, the most powerful thing I've seen is patient voice. Patient support groups are extremely powerful in changing healthcare policy.
Yes, the number one question that was submitted, which I do have later on, is about how can women best advocate for themselves. The stories of, if it was a male that had endometriosis, there had been a cure by now. They have all this analgesia and anaesthetics for the snip if they're going in for a vasectomy. Whereas from my own personal experience, when I went for a coil being fitted, I'll pop a couple of paracetamol. That was it. You should be fine. The 20-minute appointment lasted an hour and a half because I kept passing out. So it's amazing to see the difference in how we're treated with pain thresholds and what's considered normal.
Yeah, I think it's good objective evidence.
Yeah.
In the US, for instance, there's a huge research fund looking at early onset Parkinson's disease. And Michael J. Fox said in Back to the Future. But it's actually very rare. Early onset Parkinson's is very rare compared to endometriosis with a prevalence of at least 15% of the population. So it's really common. And yet, the amount spent on research in early onset Parkinson's is 160 times that of endometriosis in the US alone. And the reason for that is gender inequality.
So we've touched on endo being a systemic inflammatory condition. And I think another barrier to getting through to being able to get into front of somebody like yourself would be you've got to go through the primary medical level first. So are GPs and your primary level medical professionals getting enough training on endometriosis and anything that can prompt them to think endo before thinking something else?
The answer is no, they're not. And you could be a general practitioner in training and yet have very, very limited, if no exposure to women's health, of which, and even, for instance, obstetrics and gynecology within our postgraduate training program, endometriosis is mentioned in a very tiny amount in our curriculum. Our undergraduate training program has most undergraduate training programs in medicine now have taken obstetrics and gynecology down to 2 weeks training. So you get 1 week in gynecology, 5 days. That is it. So if you hear the word endometriosis, you're lucky. So general practitioners, it's a really challenging job, and I really do feel sorry for them because they've got so much to learn and their constraints financially and their constraints in time is so limited. But they've got inadequate training generally in endometriosis care.
What can we do to change this, do you think?
Yeah, I think it's lots of things. I think the most powerful voice is the patient voice. We've got the Endo Cymru app in Wales to put your symptoms in and say, Doc, I've got endo. And here's what you need to do because here's what the national guidance says. People are often worried as patients, but I think it's quite acceptable to say, I believe I've got endo because the app says this, and here's what you should do now in the national guidelines, and I've highlighted a copy for you. Thank you so much. And that'll save you your 10-minute consultation. The barrier, of course, is if you've got a primary care doctor who disagrees with that and then refuses. Yeah, and that does bring conflict. Bring a friend, no acceptable. Bring a partner. A male partner is sometimes useful. A female partner, a relative, it doesn't matter, but bring people.
Someone to just have your corner, basically.
And I think it because often people forget in medicine as a patient, it can be intimidating to be there. And it's much nicer to have people with you. And I meet loads of people. I meet people with horrendous endometriosis stories who come to see me in their 40s, in their 30s. And my number one wish in my head, I'm thinking, I wish I met you when you were in your teens because I could have changed your trajectory of life then.
So what treatment options would be available to someone?
So I think the most powerful things you can do when you can diagnose somebody with endometriosis, people come and see me and I say, I think you've got endometriosis because of this. And I haven't started any medication. I haven't given them pain relief. I haven't discussed operative interventions with them. And they often burst out crying at that point. And I say, I'm so sorry, but many people do. And the reason why they feel great relief and support at that point in time, because they said this is the first time somebody has listened to me. And I feel validated for the first time ever. And that is quite powerful, I think. We've got new medication and we've got some really good clinical trials of medication can not only reduce symptoms in a really significant way, but slow progress of endometriosis and even volumetrically shrink endometriosis. I've done clinic this morning and I've met a lady who we've used medical treatment on for 18 months. And she says, this is a miracle. I'm completely pain-free. Doesn't work for everyone, but it's a great opportunity to change somebody's life. So, and that's kind of where we are now. And early treatment, early effective treatment is the key. Your medical treatment and your surgical treatment are much, much more effective. Later on, it's very difficult to treat.
With the new medical treatments coming on, there's been some new development in the GLP-1 medication, where women are noticing some symptom relief, some bloating reduction. So what other sort of forms of medical treatment are there that you perhaps tried before going the surgical route, like there'd be the pill, perhaps, contraceptive, hormonal treatments. And how would you advise somebody of what route you'd think to go down primarily?
The kind of usual way on national guidelines, our NICE guidelines, people with endometriosis, we say we've got 4 options for you. I dislike the NICE guidelines, and I'll tell you why. Because of option number 1. Option number 1 says conservative treatment. That means do nothing. But actually, you've acknowledged it. That's fine. You can observe people's symptoms. But usually by the time people come to see me, they are in agony or they're desperate for children. So it's not really a valid option. We're kind of not very good at using all our armamentarium of pain relief. We tend to offer people 2 paracetamol, and yet they're in agonizing pain. And it's using the remote amount of appropriate analgesics. We use nerve blocks, local anesthetic creams and gels, TENS machines, physiotherapy. And these things are actually really effective at knocking out some of these specific pain symptoms. Hormonal stuff has kind of massively changed in the last 4 years. And in the late 1990s, we had very little treatment options. We had a drug called danazol that kind of worked, except it made your voice go very deep permanently and give you a beard. So it wasn't such a popular drug, you can see. And then we had a drug which essentially caused menopause. And then a little bit later on, there was a study done and said, well, we could use hormonal contraception, but often what people don't realize, if you use the combined pill, the mini pill, the Mirena coil, the implant, the injection, it doesn't matter which. One is no better than the other in suppressing symptoms. But in the last few years, we've had drugs that have been specifically licensed and created for treating endometriosis. And the first one, it was a drug called Gynaecologist. It's a progesterone, but it's not a contraceptive. And when that was compared to the leading drug as it was then, which was the menopause drug, and what we were surprised, it was much more effective. And we didn't expect that. So that was kind of useful. And we've had a sequence of other kind of interesting progesterones and other interesting hormonal drugs that are more effective. And we've got some really interesting things coming around the corner. For instance, one of the molecules endometriosis makes is called interleukin-6, which is a really unpleasant molecule. It's the one that gives you the flu symptoms. But now we've created an antibody that can knock off interleukin-6 production. So the idea is it doesn't change your endo, but it stops how endometriosis can stimulate nerves. So that exists as technology, and that's under clinical trial at the moment. So there is some like chinks, and you can see some little interesting trials even around the UK.
That's fascinating. What's the timeline on something like that, do you think?
It's hard to say with clinical research, and I always think, oh my gosh, it works, we're going to have it, yeah. And whatever trial it is, everything seems to take a decade in pharmaceutical research for whatever reason.
Could you tell us how you've noticed an increase in comorbidities such as POTS, Ehlers-Danlos syndrome, MCAS, lipedema, and what you think the correlation between those sort of comorbidity conditions and endometriosis is?
It's really interesting. There's a chap he's got a brilliant name, easy to remember, Stephen Kennedy, who's an academic gynaecologist based in Oxford, and he beavered away looking at the genetics of endometriosis, because we know it runs in families. And Stephen found there's about 800 different gene mutations that gives endometriosis. And what we think now is endometriosis is more than one disease. We're calling it the same label, but we think there probably is some types of endometriosis that don't cause pain, some that do, some cause infertility, some don't. So we've got this kind of, and you can draw something called a Manhattan plot is where the genes are. And then what a brilliant study was done then afterwards. They looked at people with fibromyalgia, a really unpleasant condition. Again, another condition that's been completely ignored. And people say, well, we don't know what it is. There's probably nothing wrong with you. You're probably depressed. And that is not true. I can see why people in agonizing pain become depressed. But the fascinating thing is, if you look at a population with fibromyalgia, exactly the same gene mutations as endometriosis. The genes of hypermobility, Ehlers-Danlos and POTS syndrome, they're strongly linked with endometriosis. So I see one of the things I often see is ask people to stretch their thumbs down and they can lift their thumb to their wrist. And you think, oh my gosh, that's hypermobility. Ta-da, as demonstrated. And the incidence of that in the population of people I see is really high. And these are linked. And again, they used to say people with hypermobility, Ehlers-Danlos, had a different pain receptor. Well, they didn't have a different pain receptor. They simply had endometriosis. So that's kind of, there's a strong link. There's a link between autoimmune disease, thyroid disorders that we now seem to be identifying more. I get referrals from other specialties now for instance, rheumatologists have said we've got people with rheumatoid arthritis, but we now seem to see that when their endometriosis is worse, their rheumatoid gets worse. And I'm getting people from the hematology department being sent to me to say they've got hemochromatosis, but it seems to be worse when their endo gets worse. So there's a link, and endometriosis is pro-inflammatory and seems to make other pathologies worse as well.
Yes, I found that with I diagnosed fibromyalgia, hypermobile Ehlers-Danlos and POTS, and this is all before the endo diagnosis. Yeah. So it all makes sense.
Yeah, and it is. And I meet all these really people with a really dreadful life with all these pathologies, but they are interconnected. And people are often written off then because they've got complex pathology, and people see a large set of case notes and are terrified of looking after these people and spending time. And it just needs that real extra time and effort to tease things apart and say, look, we can really help you.
Yeah. It would be nice to put all the puzzle pieces together and link it more. And again, I think that comes back to more education and training being needed for look at all these conditions and think endo. It's like when you have those driving campaigns where they say think bike.
Yeah.
Think endo.
Oh, yeah, absolutely. If you don't think, you won't see it. And you must consider it, absolutely, I agree.
So looking more specifically to Wales, what innovation in Wales is there for endometriosis or wider gynaecology?
Wales is kind of interesting. There's kind of pros and cons about Wales. I'm biased for obvious reasons. It is useful to have a government that's on your doorstep. And I think it's probably a government that actually will listen more. You can, if you want to meet a health minister, you can, with relative ease. So that's useful. Wales is an interesting population. It's very easy to recruit people for clinical trials in Wales for whatever reason. It just always has been. Our Endo Cymru app is exceptional. It is a leader in many ways. So Wales it's good for some things. It's good at rapid change in policy. Its disadvantage, and this is a problem. In our last kind of rejig of NHS Wales and NHS England, and often people think the NHS is the same when it's not. They're completely different. And the model of care in NHS England is you require complex surgery or certainly complex care for endometriosis. We are going to send you to an endometriosis centre. The endometriosis centre will open the door and welcome you and say, welcome, we like you, we will look after you. And this is the important bit, the money follows the patient. Wales did something different. And at the start, it seemed a really good idea, but it failed. And what they said, health boards would cooperate with each other. For instance, if you require complex endometriosis from hospital A to B, that would be fine. Hospital B should welcome you with open arms. Hospital A would accept other patients reciprocally. And that works, and it would work if there was liquidity of money. There isn't. So health boards argue and squabble between themselves, and now there's a perception of people don't want to take tertiary referral endometriosis because no money comes with it. And that, I think, is wrong, because you end up with a situation of your healthcare is dependent upon your postcode, and that can't be right. And that's something, that's what I protest about, and I openly say I'll protest to Welsh Assembly government, and we'll march on that one, because people should have the same level, should have equality of care. Healthcare will never be perfect, and that's okay, but there should be equality, and we are failing in Wales compared to England.
Yes, that's a big thing that I found with my parents both live in England, down in Cornwall, and even just with their NHS app, the things that they can do on that compared to the Welsh one, which, given the latest update we've had of the Welsh app, I can now see waiting lists I was on, but before I could only order a repeat prescription or try to book a GP appointment. So with the right to choose scheme in England, in Wales, we have none of that. So personally, I think we are far, far behind. Far behind.
I agree.
So what do you think that the Welsh Government can do to support Endo more in their health boards? And, how can they go about it? What more can we do? What more can they do?
I think our big thing is our British Society of Gynaecologist set up endometriosis centres. And it's without a doubt the right thing to do. We know of all your predictors of operative success, lower complication rates, higher outcomes in terms of pain relief, lowest recurrent rates of all the variables you've got is complete excision of disease. And I think governments need to recognise centralisation of services is actually good for them as well, because I meet many people who come and see me and they said they've had 7, 8, 9, 10 operations, but they've never had the opportunity of complete excision of disease. And so they've been a wasted event. So all that expense that they've used in district generals, for instance, has been wasted. They've lost that opportunity, it's wasted money, where they should have done the more effective treatment first of all. And that overall will save money for NHS care. And it's just pushing over the line and getting governments to recognise you need to support tertiary referral units for endometriosis care. There are other tertiary referral units in other specialties, and there seems to be a resistance against funding tertiary referral units and I'm going to put something very controversial because it's women's health.
So, as patients, as women, how would you, as someone on the inside of the system, how would you recommend that we tackle this sort of medical misogyny, and how can we make steps to getting this changed?
Yeah, I think huge patient empowerment, education, going with evidence-based medicine and guidelines to your healthcare provider, going on the endometriosis march. I mean, really, and then it's pressurizing, constantly pressurizing, be it the health board or at national level, and that is a good thing. Some person asked me, of all the people, who's the most inspirational person you've ever met? And I'd thought about it, and actually it's patients. And it's the patient who comes to see me with a really raw deal in endometriosis care. They've had rubbish care throughout their life. They've got to 40, life has been awful, and they can't, and I can't change their previous life, but they want to change it for other people in their teens now. They don't want to be that teenage girl rolling around in agony in school. And I think that's why it's important to highlight and protest and highlight this issue to governments.
That teenage girl was me at 14, and as I says, that's a big reason why we're here today, to hopefully improve it for the younger generation coming up behind us. So what are you hoping the next steps in endometriosis support to be?
I think support-wise, we had a task and finish group in endometriosis care in 2018, and this was the shopping list, and here's what we asked for, and they said, that's very nice, you can have a tin of beans, but you're not, it was that level. And so we got some things. We got an endometriosis nurse in each of the health boards, and and quite rightly that people congratulate themselves on that, and that was a step forward, but it was just a step on that rung. If there's anything we really could do, is kind of that compassion and early diagnosis when women say, this is pain every month. If I could support that and change that, be it in healthcare, be it employment, be it in primary care, be it in schools, that's what I'd really like to see.
That's a nice segue to bring me on to the biggest question I've had, and it's all coming in various ways of being asked, so I'm actually going to read it verbatim for what I've had, just to hopefully highlight how people are really feeling about this particular issue, and that is around not being listened to, again, the medical misogyny. So I've had, how can women best advocate for themselves when they know something just isn't right and they don't feel listened to? We know it takes around now 12 years for the average diagnosis, and the women often get ping-ponged between different services when they're at their most vulnerable. How can we make people just listen when we are running on empty? How can I advocate for myself when nobody will listen? I'm really struggling to feel heard at the moment. Why does it have to be when I'm at my breaking point and fighting to get an answer when it comes to women's health concerns?
There are groups who are quite supportive of that. There's Fair Treatment of Women of Wales, FTWW, sounds like a wrestling federation, but it's not. And they did some really exceptional stuff in their task and finish group. And there's a document which is online, and it went to Welsh Assembly Government, and it was the task and finish group 2018. And there was a lady who drew her experiences. She drew visually what she felt endometriosis was, and I can still see the picture of signposted going around various departments in the hospital. Of I went to urology, I went to colorectal, I kind of went to pain, they sent me to psychiatry. But actually she had endometriosis, and she was lost in this, come back again, come back again. I genuinely feel, particularly primary care, nobody is there in primary care who wants to harm and doesn't want to listen to somebody. And if they've been programmed in by culture and a system to not listen to somebody. And I think going to them and just, here's your task and finish group, here's the diagram, and this is what I feel every day, doc. And I think I got endo, and I don't want to be on this pathway anymore. There's another group, the Menstrual Health Project, which I work with as a charity, which again is exceptional. Again, gives menstrual toolkits, and we've got one for teenage girls as well to say, this is a toolkit, this is wrong. We try to get legislation through schools to say there would be mandated a school curriculum to talk about periods to boys and girls, a radical concept. I mean, what do we know as boys in school? Nothing, I promise you. But to say, rolling around in agony once a month, that's abnormal. And we want to support you to go and get proper help. And I think it's almost giving that, when we spoke at the start about using diagnostic tests, the real useful thing about a diagnostic test, it's got a printed statement that said this could be endometriosis. And I think that's what technology and apps can do, to say, you got a 98% chance of endo, doc, I've done it, so this is what you're supposed to do now. And that gives the patient power.
From my own experience, I've done that for a very long time. I've gone away, I've done my research, I've highlighted the things that, right, I'm ticking this box, I'm ticking that box. As I did when I came to saw you, I had it all printed out for you. But I have met, GPs and at the primary level in the past, where that sort of thing, when the patient comes in informed and they've got a direction they want to go in already in their mind, it sort of puts their nose out of joint a bit. So how would somebody go about, sort of, again, advocating for themselves or getting past that hurdle of, well, I've done all of that. I'm trying to advocate for myself. I've done my research, but they're just dismissing me because it's Dr. Google.
If there's the perception of putting their nose out of joint, carry on, is my advice, because that's what they need. And there kind of is a place for Dr. Google. I mean, that is, and it's more than Dr. Google. It's, Doc, this is the nice guidelines. This is your book as my book. We are following the same book. And I've got these symptoms and here's what I want. And what you're saying isn't following this pathway. So can you explain to me why we're not following the nice guidelines today? Sometimes it gets to the point you're thinking, I have to change. I have to get a new doctor. This is not working. I think it's quite acceptable to say to a GP, I'm so sorry, but you don't follow nice guidelines. I can't really continue with you, really. I'll write you formally.
Yeah. And so some people don't feel or maybe know that that's an option.
Yeah.
That, this is the practice I'm at. I mean, my particular practice, I never see the same person twice. Yeah. So it may be, if you're coming up against the same barrier as a practice institutional problem within the practice, you've then got that barrier of trying to change practices, because again, that's a whole postcode lottery. So knowing what other options are out there for you. If you're getting this, you can't get past the first gate.
Which is really challenging. I mean, it is. And I think having systems in play, particularly apps, that's going to change things. We have a primary care system in the UK. It doesn't exist across the rest of the world. And so, there are direct referral systems in the rest of the world. And there is, we are trying to embed education into primary care, particularly for endometriosis. But it's like all things, as we said at the start, you can only learn what you want to learn. And if I go into an educational event, I know which GPs are going to be there. And it's always the ones who are not there. That's the dilemma.
The ones that need the training.
Yeah, that's really hard.
Yes. Are fibroids related to endometriosis? How do they form? And is it possible we can do anything to prevent them?
So fibroids are lumps, essentially of benign muscle, usually inside the muscle of the wall of the womb. And some interesting stats for that. If you scan somebody on their 40th birthday, 40% of people will have fibroids. It sounds a bit more sinister, but at post-mortem, 90% of people have fibroids. So they're kind of a normal part of uterine aging. And they're lumps of muscle, they can present as a mass, you can feel it. People come and see me and are terrified because they felt a mass. But they're profoundly benign, really 99.99% benign sort of stuff. So malignancy is very rare in them. They present with heavy periods, infertility, pressure effects sometimes, and there's loads of stuff for that. I mean, there's really interesting medical treatment, there's ultrasound technology to destroy it. There are surgical treatments to remove fibroids. I do that quite often on people who have a desire to preserve fertility. But there's nothing published to say 40% of people with fibroids, 15% chance of endometriosis. To have both is quite common, sadly, but the one doesn't increase the rate of the other. The problem is sometimes fibroids are often blamed for all sorts of things. You've got pain, it's your fibroid, yeah? It's raining today, must be your fibroid. That level of stuff, and it's just coincidental.
When on HRT, progesterone is important in preventing the thickening of the lining of the womb when you're taking estrogen. Is it possible to take too much progesterone, and what would happen if you're on a dose that's too high?
Okay. HRT is, without a doubt, an amazing drug. I mean, it literally changes quality of life phenomenally. Menopause is cognitive function isn't right, anxiety, lack of confidence, low libido, a mood change, vaginal dryness, and I'm doing this in an order, and the last one I'll put is hot flushes, because often people, if you ask people on the high street or pub today, what's menopause? They say, something to do with hot flushes, doc. But it's not, it's the other things that are actually much more significant, and estrogen can significantly improve and resolve those symptoms. And sadly in the UK, we have a very low uptake of HRT compared to the rest of Europe. The closer you live to the Mediterranean, the greater the chance of HRT you've got. And the further away, particularly in the UK, we have a low uptake. And again, it's because lack of education. It's barriers to stopping people getting hormone replacement therapy in a timely and adequate way. But estrogen, if you've got a uterus, you're not allowed to have it on its own, because if you take estrogen on its own, it thickens the lining of the womb uncontrollably, and it increases your rate of a cancer of the uterus. And so that's why you've got to have progesterone. Progesterone is a brilliant drug in many ways. Progesterone doesn't kill you, it reduces malignancy rates, it doesn't affect your blood pressure, it doesn't give you clots, doesn't do anything. But if you have too much of it, it can give you a sensation of water retention, swelling, headache, breast tenderness. So they're quite kind of non-specific sort of stuff, but they're certainly there. And that's kind of progesterogenic side effects. And that's easy to fix though.
Is there any link between progesterone and issues with mental health, would you say?
Yeah, that's a very good question, yeah. I see quite a lot of people who come and see me with a kind of another condition that's often ignored, is PMDD, premenstrual dysphoric syndrome, and it's a severe illness of significant mood change to a psychiatric level, but it's cyclical, and people describe it as, I burst out crying for no reason at all, just because of it was suddenly that day, or it doesn't matter what it was. And then I look back a week later and I'm thinking, that wasn't me. I feel remote to that really. And that's often a change in progesterone level. And you can record, diarise people's symptoms. You can see real cyclicity of it. And so not the progesterone per se, but the change in progesterone level can trigger PMDD. So you can address that, and there's ways to do that.
So if you're on a contraceptive that's got the progesterone in it, or like myself was on the mini pill, the progesterone only pill for a while, and I found my mental health severely negatively impacted by that. So would it be the sort of the synthetic progesterones that would cause that, as opposed to a natural progesterone?
It's a good question. About 15% of people who take a progesterone notice a change in mood. And if you look at why people stop the progesterone-only pill, sometimes it's because of menstrual irregularity, but actually a common reason, they say, my mood goes down with it. And it's a big thing, actually, and it's not just that I feel a bit great, I feel really down. And I meet many patients who literally can't tolerate progesterones. And I said that statement is not quite true. Sometimes you can tinker the progesterones. And it's often not the case a synthetic is better than a natural. It's just one progesterone seems to be worse for some ladies than a different type. So sometimes changing the dose, or when you take the progesterone, or what progesterone it is, seems to change things.
What can we do to better support a partner who's living with endometriosis? And are there things which would help or particularly not help? And maybe how best to explore those conversations.
Yeah, it's huge about understanding. Understanding equates to support, in other words, and its acknowledgement equates to support. And I know we spoke about earlier, one of the things that I would have really loved to get through was menstrual education in school for girls and boys. They say your girlfriend is rolling around once a month in agony. That isn't right, yeah. And you can support her and help her with that. Go to the GP with her. That would be really useful, for instance. Or pain intercourse. This may not be a relationship problem. She may really have genuine with pain or intercourse, and that doesn't mean she doesn't love you and doesn't care about you. So understanding these things. And I meet many supportive partners that come and see me, and they made a huge difference. And it's kind of understanding that, and almost, you're right, it's educating partners.
As colleagues, employees at the RCN, and as the RCN as an employer, how could we go about supporting our colleagues better who have already had a diagnosis, so we know that they have endometriosis, or potentially haven't got that far yet?
Yeah. And I think that's education is the key, and organisations can provide, as demonstrated today, education for your members, your colleagues, your employees. That's really good, and empowerment. And what makes a good employer is not the help they give. Actually, people never say that to me. It's the acknowledgement. I felt really rough today. I was rolling around in agony. But my boss, my employer, faceless, regardless who that person is, said, don't worry, we understand what endometriosis is. And that makes a massive difference. That in itself is huge. Whereas other people, I hear awful stories, really terrifying employment stories that are drifting towards the dangers of tribunal, I would say, to very large companies. Timing people when they go to the toilet and things to change their tampon because they got heavy periods.
So, in your professional opinion, what sort of things, policies or procedures would you recommend an employer put in place to support an employee with endo?
And I think is to empower the employee to have documents to say, look, I work my guts out for you, but at certain parts of the month, I'm not as productive as I am. That's why I'm late today. But I'll make it up to you. And the interesting thing, and I see this all the time, people who I know who are employed or employers employ people with endometriosis, they find them the best workforce because they're determined to prove them as being more effective. So they are really exceptional because when they're clinically well, they really want to demonstrate how good they are for that company. And sensible employees recognise that. And people go for an operative intervention and need time off to recuperate. Sensible employers said, please go, please get better, because we know we're going to get more out of you and you're going to be even more productive for our company in the future. So it's more type B, HR type way of doing things, but it's definitely the right way. I've worked with many companies in the past, and the best employers were the ones that looked after their workforce.
Off the back of that, a project that I'm undertaking with our people and OD team is we're looking at getting accredited for the entire RCN through the Endometriosis UK Endo-Friendly Employer Scheme.
Yes.
So that's something that we're currently working towards.
Yes.
So would you recommend that for lots of other organisations out there?
Without a doubt, yeah. And I remember recently, I think Welsh Assembly Government have only just got accredited, and you're thinking, only just, what's going on, yeah? And then when people say that the NHS Health Board is not an NHS, is not an endometriosis-friendly employee, you're thinking, what on earth are we doing? If we can't get that right, even, how can we possibly say to one of the banks they need to sort their house out where we can't even sort our health board out?
What final advice would you give to someone that's just starting out on their endo journey?
You've done the most difficult step already, because I say to people, it is horrible to be diagnosed with endometriosis, but it's much better to know than not. Because knowing you're empowered, you've done the 12-year wait, there is really effective treatments there. There's a variety of treatments. There's no cure, but there's really is effective treatments. And going to the right people, go to an accredited centre, get the right advice, look at the national guidelines and see what is right for you. But your quality of life can be significantly improved. Your fertility can be significantly improved. So you've done the hard bit already.
Brilliant. Thank you, Mr. G, very much for your time today.
Absolute pleasure. Thank you so much.
Thank you.